Good afternoon, everybody, and welcome to this meeting of the Healthcare and Wellbeing Scrutiny Committee being held today, Monday, the 27th of July, 2026. For those present in the meeting room, if the fire alarm sounds, please leave the building by the nearest exit and make your way to the fire assembly point in the car park. The agenda papers and other relevant information for this meeting are available for public viewing on the Herefordshire Council website. The Council is streaming this meeting live on the Herefordshire Council YouTube channel and is making a recording. Others are permitted to film, photograph and record public meetings, providing it does not disrupt the business of the meeting. There are no members of the public here at present. If that changes, I shall note it. For participants in the room, please raise your hand to indicate that you wish to contribute. When invited to speak, press the button on the right-hand side of the microphone unit and speak directly towards the microphone. Please remember to turn off your microphone once you've finished speaking. Please ensure that mobile phones, laptops and other devices are turned to silent. I don't think we have any remote participants. No, thank you very much for that. Okay, so we'll carry on with item 1 on the agenda, which is apologies for absence.
Thank you, Chair. Apologies for absence have been received from committee member Councillor Kevin Tillett.
And I had apologies from Councillor Mark Dykes.
Thank you.
Item 2 is named substitutes.
Councillor Polly Andrews is present as the name substitute for Councillor Kevin Tillett.
And I welcome you again, Councillor Andrews. Your experience and you often join us, so it's really good to see you again and again. Thank you very much. Item 3 is declarations of interest. Do any members wish to declare any interest in any agenda items? Nope. Item 4 on the agenda is the minutes from last meeting, which was on the 27th of April. It's included in the agenda pages 11 to 16. No matters of accuracy have been notified to the monitoring officer. If you're content that I sign the meetings as an accurate record, please show hands. Councillor Thomas, are you happy with the minutes? Yes, thank you. Item 5 is questions from members of the public. The committee has not received any questions on this occasion. And likewise, item 6 is questions from members of the council, and the committee have not received any from them either. So we'll move on to one of our really important agendas items, and that's the adult mental health rehabilitation redesign. This is an update because we invited the Hereford and Worcestershire NHS Trust to come to Scrutiny in May last year, I think it was. So the purpose of this today is an update from the Trust, looking at the adult mental health rehabilitation services redesign. So we have got a director and a head of PMO. So we have got Scott Parker and Matt Millward, and they will talk to us about what's happening in their establishment. Welcome, gentlemen, and thank you for attending.
Fantastic. Thank you very much, Chair, and thank you for inviting us along. I think I'm just going to start by doing a little bit of a recap of where we've got to and where we've come from. And then between us, we're going to talk through some more of the detail which is contained in the paper, and then move on to questions. This all started a couple of years ago. So for those of you who are perhaps newer to the committee, I'm just going to do a little bit of the history of how we've got here and what our organisation does. As a trust, Hereford and Worcester Health and Care Trust run a lot of services across Herefordshire and Worcestershire. So those include physical health, community services, predominantly in Worcestershire, a range of children's services across both Herefordshire and Worcestershire, and a range of mental health services across both Herefordshire and Worcestershire. Overall, in our delivery teams, there's over 4,000 members of staff, and most of whom are residents of Herefordshire and Worcestershire. Our strategic ambition is about the right care at the right place at the right time. And that is how this programme really came about a couple of years ago. And that was about making sure that we've got the right mental health rehabilitation services for the people of Herefordshire and Worcestershire. So at present, we have got 3 inpatient mental health rehabilitation units. And as you'll see from your papers, those are Oak House over in Hereford, Cromwell House in Worcester, and Keith Winter House over in Bromsgrove. They total, 33 beds across the 2 counties. The purpose of rehabilitation and in the rehab units is very traditionally been about, can you support people to build the skills to return to home? There's 2 types of rehabilitation units. There's type 1, so rehabilitation which is focused predominantly around community and building daily functional skills so that people can live independently. Then there is level 2, which is intensive clinical stabilisation, and it's important to just understand the difference between the 2 of those. Overall, the Royal College of we work the Royal College of Psychiatrists and also the Getting It First Right Time programme to really understand how we can reduce unwarranted variation, reduce the need of out of area placements, so that's people being placed potentially a long way away from their homes, so keeping people as close to home as possible. Making sure we've got absolutely clear rehabilitation pathways, making sure our workforce is sustainable, and ensuring that we've got buildings that are really suitable for the purpose. Since the last, I was getting carried away there. Matt was going to come in at that point there.
Thanks, Scott. Thank you, Chair. As the head of the PMO, which is the Programme Management Office, I'm just going to touch a little bit more about the process that we've been following as part of this journey, this programme. So it's been extensive. It's been going on for a couple of years now, and it's been inclusive. We've done a lot of different engaging with lots of different stakeholders, and we've got patients participation partners or experts by experience who are also part of the programme, who sort of hold us to account for how we're progressing with what we're doing. Just to take us back to the beginning of the process, we started off with some clinical modelling sessions with a whole range of stakeholders. And apologies, some of this may have already been in previous papers, but just recapping. We had 7 potential ideas, and then following the NHS major change process, and applying different levels of criteria to these ideas, we slowly start to whittle them down. And we've taken a few different approaches to doing that. Sometimes it didn't work and we had to change direction. But essentially it left us with 3 viable options, which would have made up the final options appraisal. To do that, we established some expert groups. So rather than just put the options in front of one person, say, and expect them to make a decision, we ran it through expert panels. So they would focus on very specific topics. So we would have had a panel that looked at quality of care, which would have been made up of a lot of clinical staff and also some of our experts by experience. Access to care, so that would have been attended by our diversity, equality and inclusion colleagues. Workforce, whether it was sustainable, what the impact would be, and that would have had people from the services, people managing the services, and people from human resources. Deliverability, which is people like myself to try and actually establish whether we actually can deliver such an option. Environment, so we would have had people from our estates who would have been advising us on what buildings would have been best and what state they were in. And then finally, affordability and value for money would have been our final panel. And on those panels, we had a huge mix of people. We had people from local authority, VCSE, integrated care system colleagues, participation partners, and obviously trust staff as well. And we've also engaged with public health colleagues who've supported us with some work on population needs and some data as well. And you back to Scott. Thank you.
Thank you. So the preferred options, obviously, as Matt said, we started off with 7 options. When we looked at all the criteria, it worked through to being the preferred option, which was the development of a community rehabilitation team for level 1. So that's the functional daily skills bit we talked about earlier on. Maintaining a smaller base of beds, so moving down from around 33 to 18 beds, and then working with through a procurement option around level 2 rehabilitation beds. So why did we go for those particular options? Well, the mix of keeping people close to home, the capacity that it would give us, and ultimately those outcomes of remaining close to home were the key drivers. As an example, by having the community rehabilitation team, it gives the and less beds, it gives us well, you know, whilst it was a reduction in 18 beds, so 18 people able to access the service, it will, that's workforce in the community, will it enable us to support 135 people. So it is quite a significant rise in the number of people we can support. And of course, the principle is about supporting people, daily lives, functional skills. So it fits with what the ultimate aim is. It's about individuals and their needs, and ensuring that we're building bespoke packages for people to support their recovery. During 2025, I will note though that we did pause the process because there were new providers came into the market around the bedded facilities. So there were some in Herefordshire and Worcestershire. So we did pause the process at that point to allow them to come in to the considerations. Despite that, that didn't affect the final outcome of the preferred option.
Thanks, Scott. So I'm just going to kind of cover now really what the next steps are. So as I mentioned in the first part of my presentation, I talked about the NHSE major change process. So there's a lot of different assurance checkpoints that we have to go through. So the next one that we've got is you may or may not be aware of a group called the Clinical Senate, who are an independent group made up of medical professionals, experts by experience, and other stakeholders. They will review everything that we've done. In August, they'll be visiting the trust, and they will visit the sites as well, and they will look at everything that we've collated over this time, look at the way we've managed it and how we've come to the decisions that we have, and they'll sort of write a review of that. And then once the trust and the integrated care system have reviewed the clinical senate findings, we'll go through an NHS England stage 2 assurance of gateway checkpoint. Assuming that all of that is successful and we get the sort of the tick to move forward, in early 2027 we'll be looking at formal public consultation to run for 12 weeks. I think the really important bit here to say is that we're coming with you to you today to just tell you the point that we've got to, and the point we've got to is that we have arrived at a preferred option. There are still some steps to go yet. We're not here to say this is definitely what's going on. This is just the point that we've got to, and we've now still got to jump a few hurdles. Thank you.
So really, that's brings us to the end of the whistle stop tour of 2 years' work, and so thank you very much for listening, councillors, and very happy to take questions.
Thank you. Thanks, Scott and Matt. You'll have to bear with me. My laptop keeps going black and then coming back and then going black. So we'll see how it goes. Right. Can I start off with a few questions about access? You know, we talked last year about the concerns for our local residents. At present, we've got 8 beds, is it, in Oak House, and that's going to be closing. So where will Herefordsians or people who want to stay in this area, have an opportunity to go to.
Thank you, Councillor. So, obviously, with those beds going, there's less bedded facility within Herefordshire. The reflections on that unit is they are not currently able to support all of the needs for people to support them back in their own homes. So by closing that facility and using the resources to work in the community, we'll be able to support more people in the community in their own homes, but then in reaching into other kinds of accommodation where people are currently living. If they do need bedded capacity, then we have the unit in Bromsgrove. And ultimately, if if the need arose, then unfortunately, then it would mean out of county. The modelling from the two public health departments in Herefordshire and Worcestershire indicates that we shouldn't need to go out of county. So this should mean that people are able to be better supported close to home.
So can you reassure me that out of area placements are reducing?
So there's a number of pieces of work at the moment. Out of county is reducing. This will then take us to a different place, particularly for rehabilitation.
And are there waiting times for this?
No.
Nobody's
No.
waiting for opportunity. No. Councillor Andrews.
Thank you. I wonder if you could tell me a little more about what you're going to do in the community provision. It's just that I've been around a long time, and I remember when the psychiatric hospitals closed, much was made of the community care, which didn't actually seem to manifest itself very successfully. So I just wonder how you are going to provide this community provision in our very rural county. And how are you going to do it, and who is going to do it? And what the cost is likely to be also.
Well, at the moment, the way that we're working is on a cost neutral basis, and the staff that will be in the units that that we are proposing as part of the preferred option that will close will also be trained into being given positions in the community rehabilitation team. There's obviously a lot of work around that's going to need to do that, but that's the aim of how we're going to provide it. The whole. I understand what you're saying about not manifesting, but once this is made, a whole new program will be set up to actually really start to implement all of this straight away.
So it's not there yet. You're still in a setting up stage, and you've still got to retrain the staff.
Well, we're not at the. Oh, God,
retrain the staff, if of course they want to do it, to a different form of working. Thank you.
Yes. So I've gone red now. There we go. Yeah. So obviously the stage we're at in this is about we're at the so we've been through the options appraisal and we've come to the preferred option. This still needs to go through the NHS England sign-off processes. So once it's once it's navigated those processes, we'll then obviously have a full public consultation process. After that, that's when we would actually start to make changes to services. But it would be about having the right staff mix of people to work in the community. I mean, I live in Ross myself. I understand the geography of Herefordshire. Would work very closely with partners as well about how do we best deploy the resources to make sure we meet everybody's needs.
It sounds wonderful, but I've seen this sort of thing in practice, and it doesn't work quite as well as you seem to think it might.
I think we just have to watch this space, don't we?
Yeah. Very much so, yeah. I would think so too.
Yeah. Councillor Thomas.
Why close Oak House? Because it's going to leave Herefordshire without any secure, and unfortunately, there are a lot of people that need secure accommodation through mental illness. So are you going to ship them all off to Worcestershire? Because you can't, if somebody is, and I do know because I've had this problems in my family, if somebody has to be sectioned, you can't just send somebody to their house. They have to be in a secure unit. And you seem to be, we have Stonebow, so why are we not using that?
So there's a couple of different things here. So Stonebow, the site up at the hospital, the acute unit, nothing's changing there. This is about the rehabilitation services. So Oak House, it's not a secure unit in the same way as the Stonebow unit is, for example. And it's a lot more about the people there being able to learn skills which help them remain in their own homes or wherever they're living, while still being able to access the community, and try to find work and things like this. So there are two different things there, but I can categorically say this plan would not see any impact on the secure bed stock.
Yeah, thank you. Councillor Tully.
That's helpful. Thank you for that. And was just around a little bit more, perhaps, of what Polly was saying as well, to do with the overlap. So I understand that phase 5 is actually happening, and that's still, it's mid 2027, so it's actually not that far away, is it? And so as I understand it, there's some kind of overlap there, but it hasn't happened yet. And I think Councillor Crookett asked about waiting times, and so obviously there are no waiting times because there is no new service, of course. But what do you foresee as that as any of those issues in the crossover time? Because I think it's great if people go to a space where they will be therefore living and where they need to live and they are being rehabilitated is brilliant. And have you looked at any of the risks that are around housing? Because as I understand it, some of the issues that have been in place with people going out of county for certain things is around the availability of housing here. So however great what you're doing is, it requires somebody to have somewhere to live. So what are the risks of that, and how are you managing those overlaps between one service ending and the other beginning?
Thank you. I'll just go back to the beginning of the question. I won't be able to answer the question on housing, but in terms of the phases, the phase 5, that cannot happen unless we successfully achieve phase 4. So we've got to go through that checkpoint first. As part of the documentation and the evidence that we submit to the clinical senate, what will be contained in there, what is contained in there, is a very high level proposed, as you'd say, about like a crossover plan about how it would work. Obviously, not that we're there yet, but we wouldn't be in a world where something would just close and something would just start. So all of that is being considered, but it would be far too early in the day to have something more detailed than that. It's just to show that we've covered it from a high level point of view and of what roughly our approach would be if we do make it to phase 5.
Yeah. First of all, there's some really good questions in there, so thank you. I think so what you would see if phase 4 is navigated, then the full implementation plan would be developed, but that would include the transition plan, because you're absolutely right. You can't just stop the one provision and then the next day you're in the new provision. So there is a period of staff training and staff redeployment. And I would envisage it would be a staged approach, and we would need to overstaff for a period of time to make sure that we're able to run both offers. So that would be that high level. That would be the process that we'd follow. And obviously, if assuming we get to that stage, we're obviously very happy to provide that plan back for councillors, as it is a critical one. The the housing provision, again, it is a really, really good question. So there's obviously a number of complexities there in Herefordshire. Our absolute first focus is about working with people in Herefordshire. Obviously, if there's a placement elsewhere for other reasons, then we'll have to put in specific plans for those individuals. But I do think the work associated with 117 funding, so work between the council and also ourselves and the ICB. That's actually quite critical to making sure that we're getting the right provision in the right place for people of Herefordshire. So there is outside work, which I think it becomes even more important so that we can keep people close to home.
For the benefit of people that don't know what 117 funding is, of course I know exactly what it is. But could you just explain that? That sounds like stuff that you're doing in partnership, which I think sounds really interesting. So it'd be lovely to just have that clear. Yeah, that would do.
Cool. No, thank you, Council, and apologies. So 117. It is where the funding that enables somebody with mental health conditions to be able to access things like housing and services in the community, and it's a joint piece between Herefordshire Council and Herefordshire and Worcestershire ICB. So there is the assessment of needs and then agreement of funding packages there. As a provider, we have opportunities around what the provision is for people, which can influence that. But again, it is a whole system piece for how we operate that effectively.
And for anybody who doesn't know, ICB is Integrated Care Board.
That one I know.
Yeah, that's all right then.
Sorry, Council, I'm chucking my NHS abbreviations. I'll watch myself on that.
We all work in that field, don't we? But all the members of the public that are watching this perhaps don't. So just thinking about your comments about housing shortages, and do you think that's delaying any discharges? Because obviously Oak House only has so many beds, and then you're trying to get them to move forward to, living a productive life, shall we say. And I know that your teams are working with social housing groups, because there's an estate that's just opened in my ward where 5 houses are dedicated to people with mental health issues or concerns or needs. So I think we as society are acknowledging that, and the social housing providers are too. So I think that's a really positive step. You mentioned experts by experience, and I just wondered what the service users do say to you. What do these experts say? And also on the back of that, what are the staff feeling and thinking about these changes? Sorry, there's a few questions there, but I was off.
There is. So I'll pick up in terms of the housing. I don't know of there being any existing long-term challenges. Yes, there's sometimes individual requirements that take a little bit of working through, but by agencies working together, we always come up with a solution. In terms of the feedback from patients, experts by experience, and staff, there was a whole process within this. So I'm going to hand over to Matt just to give some headlines from that.
Yeah, we've got a couple of experts by experience helping us, and it's been a mix. They've challenged us. Make no mistake, they've challenged us, and they've raised concerns, and they've raised concerns about Herefordshire specifically. But it's been fairly balanced. I think they've been quite impressed by the lengths we've gone to as part of this programme to engage all the different stakeholders and the thought that's gone into what we're trying to do. I believe it's the first time we've done anything in this way before. But yeah, so there's it's been a balance, a lot of challenge. That they've got a strong voice as part of our program board. So what they do say also gets heard by our senior responsible officer for the program and program directors. So their voice is used. In terms of staff, I think again probably there's a mix. There's obviously a bit of concern about what will come with the future. There has been some positives, and kind of they can see what is being proposed is, possibly an exciting challenge, and it could help serve more people across the populations. But there's obviously the usual concern. But we visit the sites. When we arrived at a preferred option, we split into teams and we went to all the sites and we specifically told them where we'd got to in terms of what we'd identified so far. We put in drop-in sessions. We've got a lot of communication channels open with them. So I suppose on both counts, it's been mixed but challenging. But yeah,
it is, and it's really really important to really acknowledge that we've had staff who've worked in Oak House and Cromwell House for a long time, really really dedicated people, and it's the work they've done over the years has been amazing. And this programme of work is no reflection at all of what they've achieved or the outcomes achieved. It is about that move to a model that is more consistent with national best practice, which obviously evolves over time. And I think that the staff feedback is generally been recognition of that, of it, actually, yes, it is, you get better outcomes of working with people in the community. But of course, there is that passion and relationship with the buildings that they've worked in.
I think it's quite common, isn't it? Any service change, initially the staff always get a bit anxious about, where is this gonna end up? How is it gonna help me? How is it gonna help the service users? So it's good to hear that you're engaging well with them and listening to their concerns. Just going back to the patient's feedback, has anything changed from any of that feedback you've had?
Yeah, one of our experts by experience flagged about a potential opportunity, and it paused the whole program for around 3 months whilst we explored that. And also we took on the concerns that they'd been raising, and we literally just stopped everything we were doing and started engaging with some of these new opportunities that had emerged. They didn't prove to be successful, but we wanted to make sure that we had gone down that route and documented that. And also I think I mentioned in the bit when I was talking about the process that not all of the methodology we used to whittle down the ideas was successful, and we had some quite strong feedback from a participation partner, expert by experience, about how it wasn't particularly successful. So we kind of went back to the drawing board on that as well, and came up with a newer process, a nominal ranking process. So yeah, we're listening.
Thank you. It's been a really long process, as you say, and I don't know what this nominal group ranking technique is. Can you explain that to a simple simple
Yeah.
explanation for me?
Okay, I'm just trying to think of the best way to explain it. I think we were trying to apply we followed something called the options funnel, where essentially you take a group of ideas, you put them into a funnel, and at different stages of that funnel is a filter, and each time it hits a filter, a few more ideas that make it through. And we started off with hurdle criteria, what we called hurdle criteria. This is the most basic criteria. Is it like clinically possible to do this? You ask yourself those really simple questions, and then you apply some desirable criteria. And it was at that stage that we kind of felt that the feedback we got was that it hadn't quite worked. We were trying to apply some quite complicated metrics and measures to something that wasn't quite fully formed. So we went down the route of nominal group ranking, which kind of allowed you to. It's a process where you are presented with the ideas and you rank them, and then you are left with the rest of your peers to discuss them. And it could be that your ranking changes based on the conversation that you have, and then you re-rank if you need to, or you remain as you are. So it was that sort of thing. At that stage, we just felt we had to simplify it a lot more. So that's what we did.
Yeah, when you were just saying about the sieving, it just took my brain to like genetic screening. I used to do some of that, and you go through like a sieve, and you get so many come through, and so many stay out. But yeah, I can relate to that one now. Councillor Andrews, and then Councillor Davies.
Right. Oh, thank you. Community, you said community, but you went on to mention intensive rehabilitation. Now, if you're closing Oak House, the people who are wanting intensive rehabilitation, what is the facilities going to be for them?
Yes, so this is the level 2
Yes.
rehabilitation.
That's the one we need more information about.
Yeah, so level 2 rehabilitation, we don't have any of those beds in Herefordshire, Worcestershire at the moment. So we go out of county or use slightly different approaches with the acute mental health beds that are within counties. So what we'll do is we will work with external partners and those as close to Herefordshire and Worcestershire as possible to make sure we've got the right number of beds for required for level 2. So it's not something we have at the moment.
So there's nothing in place at the moment.
No, apart from going out of county. So we'll be doing.
Anybody who needs intensive rehabilitation in Hereford at the moment will still have to go out of county.
Yes, so if they require the clinical stabilisation, then yes.
Thank you.
So yeah.
Thank you, Chair. In your presentation, you said that we currently have 33 beds for rehabilitation, and we're going to lose 18 of those beds. And then that would allow us to have 135 home in-community rehabilitation capacity, I assume. Is that the anticipated requirement for the rehab in the community of 135? And if that's the case, and we currently have 33 beds doing rehab, how do we manage the rest that aren't in those facilities?
No, thank you for that question. Yeah, so it is about changing the model that is operated, and actually we're able to have that dedicated facility in the community for that number of people. Currently, obviously, there's the 18 people who are in the beds. They're getting access to those services, but currently, people would also draw on a range of services from other community teams, but maybe our community mental health teams. So it would be about that, making sure we've got the larger pool of expertise in the community, and then that would have the impact of potentially freeing up some of our other community teams as well.
So do we have volunteer agencies that we're in part, or that you're in partnership with, that provide that assistance at the moment, and will that remain in the future?
Yeah, well, working with voluntary sector partners is really, really important, and that's around whether it be beds, places for people to go to get support, different people to talk to. So one of the things I'm really passionate about is making sure that all of those services are properly joined up with our models as well. So yeah, there's certainly no plans to back away from any of the work we do with voluntary sector. Thanks.
You mentioned partners, Councillor Davis. So I just wondered how well community mental health services are working with adult social care.
So obviously there's a wide range of work happens with adult social care. That's ranges from planning of discharges from acute units, supporting and maintaining people's conditions in the community, but also understanding we both have a role when, if somebody's condition does change, and obviously we mentioned the 117 earlier on. I think the ways of working are good. We the challenges of the Herefordshire geography is something that impacts both of us. But we are, as talking with Hilary, obviously the relevant director, and about opportunities for collaboration and work, and doing a bit of a session in the Stonebow unit so that we can really start to understand each other's services better and making sure that we're doing everything in as productive way as possible.
Thank you. I think partnerships and obviously the voluntary sector is really important in this. Councillor Andrews, you want to say something?
Uh, I get back onto the more sordid question of costs. I mean, delivering services in this county, as we all know, is expensive because of the rural nature of the county, and it is more cost effective to have people in, say, Oak House, where rather than scattered all over the county. So, how are you going to manage with the financial costs, particularly in the long term?
Yeah, so the cost of a physical building and having fixed space is very high. That's when you spread that resource across community, it actually gives you that extra stretch. The costs over time in the NHS, obviously, they go up like they go everywhere else. That would be taken care of through the contracting work with the ICB, as the normal services would. Yeah. Oh, there is actually, yes, one thing to add on that. We did actually set up a hospital at home team, which was this very principle of moving from a physical bedded environment to a community offer, so that we have actually got experience of running this kind of process. So yes.
Thank you. Thank you. So Councillor Gandhi would like to ask something, and then we perhaps will go to. Did you want to ask something else, Councillor Tully? And then Zoe, perhaps from the public health side of things, she might want to say something. So, Councillor Gandhi.
Thank you. So I used to live in Worcestershire. I used to live right in the north, but I now live and operate within a very rural part of Herefordshire. And I'd like to know what the arrangements would be for people at level 1 in units in Worcestershire, one of which is Bromsgrove, which I know quite well. I worked there for a while. How they're going to get there if they don't possess a car, which a number of them are, because there is no direct route.
Yeah. It is a very good question. Certainly something that we would have provision for in place, but the exact detail of that we haven't worked out yet. So would have to come back to you on that one at the time.
So one thing would not be to provide funding to that visitor, because that would not help them in any way whatsoever, because they still would not be able to get there. So it needs to be something that is other than funding.
Yeah. Like I said, we're going to have to work through that one still. We don't have the well, I don't have an offer for that yet. So that is on the list of something to work through.
One to keep our eye on. Councillor Tully.
There's a lot of eyes needed
Eyes,
to keep
yes.
our eyes on.
Yes.
Yeah, that just a thought on what Councillor Gandhi said is just around the decision making to get to this point, and then obviously to get to the finalised point, that the considerations feel quite important for that, being able to get to that part of Worcestershire for residents of Herefordshire, and how transport is. It seems to me that that's part of the decision making process, and may even be a reason that this option isn't taken forward, because that does seem quite a big thing to be still grappling with. I think from what I'm learning, that being for our residents, it's out of county, and for those residents, family members, it's a journey, and that has a really big impact ongoing on adult social care, and our ability to pick up the service later for people living in Herefordshire. So that does feel like quite an important piece to be aware of for you guys in your decision making. So thank you for listening. Then when we're talking about level 1, so level 1 is about in the home, and you're talking about closing something with a relatively small number of beds, and being able to do something that feels more community based. So I realise that this is potentially in your stage 4 plan, and maybe more. But how much connection is that plan going to include with your own hospital at home teams, the care in your home that is emerging from adult social care, and the community connectors in Talk Community? It feels that needs to be sort of baked in the plan, and I know that some of that in adult social care has gone more in terms of areas, so it's not so much with providers, but it's more in terms of areas and localities, and how much of that would be actually a partnership of what you're managing in localities, as opposed to just a neighbourhood, across the county. Thank you for listening.
No, thank you, Councillor. No, and you're absolutely right. With the construct of ways of working through One Herefordshire, you have got those defined areas. We obviously, from a mental health perspective, we've got a number of teams who fit into those areas at the moment, and equally the model, the actual operating model. It would be constructed in the way you say, which is based around the partnership working, and working within the various neighbourhoods. Because there are lots of opportunities in there. So I think there's lots of opportunities there of sharing expertise, to make sure we get the best outcomes for people.
So I guess then I think you offered, and I think that would be great to see what you are going to be sharing with the Senate, because it sounds like there's your plans for how the services will overlap, how one will close and one will begin, and then the shape of those services feels like that's something that's going to be developed before and to that Senate stage. Therefore, it would be great to have that in the scrutiny.
Yeah, at some point we'll be able to provide you that, but as part of the Senate, it will be more about all the evidence that's been collated and all the work that's been done, and engagement that's been done to get us to this stage. We'd then have to work everything up even more, and then do the public consultation. So that then we've still got that bit to do in state, and that's, I think, stage 5. So we've still got to go out and actually consult. We have done pre-consultation work when we first. So I know it's slightly going off topic, but when we embarked upon this, we did pre-consultation work to go out to the public to say, this is what we're thinking of doing. We are thinking of going through this process. We think these are the ideas that we're going to start to do work on, but we will have to do a full consultation at the start of next year, once we've ticked all the boxes we need to tick.
And just reinforcing that, obviously we're getting into some quite detailed how questions now. They will be flushed out during that phase of the process. So,
Thank you. Zoe, did you want to say anything as you obviously are involved with in your role with this agenda
I've
item.
got a couple of points. Thank you, Chair. In terms of very welcoming that you've involved my team and the Worcestershire Public Health team as well. So we've had input into that, and also very welcoming, obviously, in terms of that patient experience, the voice of people with lived experience. I guess, as you would expect me to say, my main picking up on Councillor Gandhi's point around the transport, my main concern or query is around that we don't widen inequalities, both in terms of access to services, but also in terms of those patient outcomes, but also Councillor Tully's touched upon it in terms of those wider outcomes of the family and those that support the patient as well. So just making that point that I know that you'll both be fully aware of, but to note that point in terms of not widening those inequalities. And clearly we're involved through the sort of Better Mental Health Partnership and 1HP in terms of those conversations.
It is, and yeah, no, fully aware, and I suppose when we come back next, we will have done more of that work, and we'll be able to provide assurance that the work's been done in that space, and hopefully by that point there, you'll be able to assure it on committee's basis. Thanks.
Thank you. Councillor Thomas, you wanted to say something?
I do appreciate that everything changes, has to change. We have to keep going forward. But mental health and physical health are very, very different. They're chalk and cheese. And I think to some extent you are trying to impose what we normally get at cottage hospital and nurses in the community. I think, well, I think it's a badly thought out plan, but I think it's not a good, well thought out plan. And I have the feeling, my senior feeling, that this is more about saving money than it is about giving a good service. And I think Herefordshire is going to come off very badly on this one, because you're closing Oak House, which is the only place that can give this type of treatment for rehabilitation. You know, if you were doing it in the home, taking them out, maybe out of Oak House after a period of time and supporting the community, I could understand that. But this to me it's just, it's not, I don't think it's a goer personally, and best of luck to try and get it going. But I really do not think it's goer, and I think it's more about National Health trying to save money rather than provide a better service.
I mean, thank you, Councillor. I mean, this is all based around national best practice, and it's been thoroughly considered through that process. So it does indicate that this will improve outcomes and improve quality. There is, though, I understand the concerns around money, but this is not about saving money. It is about investing money to get the most from it, and this is something that will be monitored through its implementation, assuming we get to that bit there. But that clinically about those outcomes, that will be thoroughly tested at the clinical senate. So the assurance that you'll be able to have as a committee is that it will only get through there if the clinical senate accepts that this is going to meet those criteria around outcomes, around meeting national best practice, and then locally as well, assuming we get to that implementation point. There's a whole series of metrics, obviously, that would be monitored, including obviously feedback from the people who are receiving the service. So I trust me, I do understand your question and point. We're very committed to providing the evidence through the clinical senate for that sign off, and then if we do get to implementation, for providing the Herefordshire community with the evidence of the impact.
Okay, no more questions. No more questions. No. Okay. Okay. So, no more questions, comments, or concerns from anyone on the committee? Nothing else from Councillor Gandy or officers. So what I would like to just finish off with, so next steps, you are next month starting with the clinical Senate visit, and then that will lead on to the trust and the integrated care board having a review and considering the steps forward. And then hopefully you're going to bring everything back to scrutiny in May next year, is that right?
Yeah, I mean, that'd be fine. I'm trying to think if it's.
Will be done by then.
Yeah, the public consultation will be done by then. Yeah.
Yeah, I was just thinking May's not going to be the right time, so
Yeah,
it's,
if I might jump in, I think it's going to be July, August at the earliest. If that sounds like that might work better for you anyway.
Yeah. Thank you.
It is. We can obviously there'll be other routes for keeping updated on the groups that Zoe mentioned, and of course the feedback through the public consultation process as well. So
yeah, well, there's always somebody having a look at other ways of finding information, isn't there, Rebecca? No, so thank you very much. So the objective of this was to actually look at the covering report, and that the committee reviewed the rehabilitation service redesign, including assurance that the committee's recommendation was acted upon. Are you all comfortable with that? Yes?
As I say, I think there's still a lot of work to be done.
Yes, yeah.
We have to wait and see how it progresses.
Absolutely. Can I ask you, Daniel, are there any recommendations?
I don't think so. I think they've been addressed in the meeting, and obviously there are a couple of actions in there. So we'll keep an eye on that extra information, and we'll supply that in advance of your meeting in July, probably.
Okay, thank you. Okay, thank you. So again, thank you both for attending and giving us a lot to think about as well as act on.
yeah, and Ryan, thank you very much. The questions are all really, really helpful in helping us shape the work for the next stage. So no, thank you for having us along.
Thank you.
Thank you.
So we will be moving on to the next agenda item in a second. Just got a few people exiting and entering. So item 8 on the agenda is the Herefordshire Joint Strategic Needs Assessment and Neighbourhood Profiles agenda item, and we have 3 officers in the room to go through this. So the purpose of this is to review, and I'm going to say the JSNA because I've already said it in full once, and the health profiles. So we have Zoe Clifford, who's the Director of Public Health, Charlotte Worthy, I can see, who's Lead Public Health Intelligence Analyst, and we've got Badri, and I'm not going to try and say your surname without you telling me it first, and you're a consultant in public health. And sorry, I don't mean to be rude, but it's just, please, I would say it wrong, so please tell me how to pronounce it.
It's Padmanabhan.
There you are. Thank you. No disrespect there. So we'll start with you then, Zoe.
Thank you, Chair. And if we can share the presentation. Oh, thank you, Charlotte. And I'm very grateful that I didn't have to pronounce Badri's surname either. So.
We'll be okay with that.
That's fine. Okay, so we've done brief introductions anyway, and we're here this afternoon to talk about the Joint Strategic Needs Assessment, but with a more focused view on what I think is quite exciting, our neighbourhood profiles, because this plays into neighbourhood health, and we'll talk you through the development of those. But I say it's quite exciting because these are fairly hot off the press. So what you're seeing is in its draft form, and we would very much welcome your views in helping to shape those. We can talk through what we're going to do with those. So plan for the presentation. We've got a brief presentation for you to update you on the JSNA, but also to look at these new profiles as well, which are in your pack. To talk about our approach to the JSNA, to talk about the approach to those neighbourhood profiles, and then also to give you a flavour of some of the insights from that. There is a huge amount of detail in those profiles, so we will only skim the surface and give you some insights into similarities and differences between those key neighbourhood areas, and then also give you an example of where we've already started to apply this, even though the product isn't quite finished, and then open it up for your questions, scrutiny and discussion. Okay, sorry, there's a slight delay on moving the slides forward. So I think you'll probably all be familiar with the Joint Strategic Needs Assessment, but I thought it was useful just to recap what this looks like in terms of a product. So I think quite often there's a misconception that the JSNA is a standalone product, that it's a document that's published at a point in time. But clearly we know that data comes out at all different times, and therefore this is an iterative process. We're on a 3-year cycle, so we publish an overall summary of what the health and care needs look like for our whole population in the county every 3 years. And that's the Joint Strategic Needs Assessment summary. But there's a whole load of other products that sit alongside this as JSNA. And just pointing out that this is a statutory obligation, that we have to have this. It sits under Health and Wellbeing Board, but it's so much more than just the responsibility of the Health and Wellbeing Board. And actually it contributes to our planning, our strategic planning and our commissioning, and also how we monitor and evaluate in terms of population health and wellbeing needs and care needs as well. So as well as that standalone document that's refreshed every 3 years and was done about 18 months, 2 years ago, there's also these supplementary products such as the one that we're going to talk about this afternoon in terms of these neighbourhood profiles, but also a whole host of bespoke needs assessments around particular themes, so that actually you have that really detailed information we've just heard in terms of mental health. So we have a mental health needs assessment. We've recently had a needs assessment that's been completed around cardiovascular disease that really goes into the detail of the patient journey for that. And then also that monitoring and surveillance side of it as well, so where there's various dashboards that are updated more frequently, so that stakeholders can view those and really understand in terms of trend and how we compare with other local authorities and how we compare with England average. And I did want to point out as well, and I know that you'll all appreciate this and be fully aware, that actually the JSNA is not just about health as in health services. We know that what gives us good health and wellbeing for our residents here is so much broader than that. So I really like this infographic that's taken from the Health Foundation that actually says about the building blocks for health and wellbeing. And that actually, you know, the food that we have access to, the jobs that we're in, our families, friends and connections, transport, which we touched upon in the last presentation around mental wellbeing and mental health services, our surroundings, all of that. And therefore the JSNA tries to look across all of those wider determinants. It doesn't just look at health service use. And I think that's a really fundamental point to labour slightly, because actually that's huge. And therefore it ends up with a very big document, but gives us a good sense of who our population are and what's driving those health and wellbeing outcomes. And just to continue on that, I mean, it wouldn't be public health, would it, if it didn't have this onion diagram in terms of, on the left-hand side there, in terms of really pointing out those wider determinants, those building blocks of health and well-being, but also to say that we know that health services, there's various estimates, but health services give us about 20% of our health and well-being. So very much JSNA might look at the health service side, and through the neighbourhood profiles it does, but it also thinks about those wider determinants, the health behaviours, the environment, the social economic factors, and starts to weave those together in terms of what does this mean for our residents and the outcomes. And I will pass you on to Charlotte, who's now going to talk to you in terms of the neighbourhood profiles.
Thank you, Zoe. Hello, everyone. I'm Charlotte Worthy. I'm the lead public health intelligence analyst at Herefordshire Council. We're going to move on to the bulk of the session now, looking at those neighbourhood profiles that we've been developing. Excuse me. So I'll start with a little bit of time on what they are, why we're doing them, and how we've gone about it as well. Excuse me, I'm driving both laptops here at the same time, so I'm going to try and stay in sync. Okay, so first question to answer is why neighbourhood profiles, and why now particularly, I think. So as Zoe said, we're midway through the cycle for the big county-wide Joint Strategic Needs Assessment summary. And lots of the work in recent years has been topic-based, focusing on those particular service needs or population group. And that kind of work is always looking at variation around the county. But it's been a long time since we pulled them together into a strategic understanding of area-based needs. And also with service provision geographies expanding and professionals working further away from home and not necessarily knowing the areas that they're working in, we felt that these sorts of insights could be particularly useful now. Obviously also aligns really well with the National Neighbourhood Health Agenda and with Herefordshire being one of the 43 Wave 1 sites around the country. So the JSNA Strategic Partnership Group agreed that the focus this year for the JSNA's main output this year would be on producing neighbourhood profiles. So we then needed to define what a neighbourhood profile should actually be. So I'm just going to briefly, I'm not going to read all of this out at all, just to briefly explain the brief that we set ourselves and the approach we took to developing them. So the main aim was to produce something that someone with no prior knowledge of an area could pick up and get a clear understanding of what the big issues are in that area. And we wanted it to complement the JSNA summary. So we focused on how areas differ from the county, rather than repeating everything that applies to Herefordshire as a whole, which is already in that summary document. And it was also important that we were adding value to existing understanding. So, for example, of patients already, GPs know the needs of the healthcare needs of their patients. So we chose topics that would most effectively highlight opportunities for prevention and for reducing inequalities. There was also an element of being pragmatic and including analysis that already existed or could be done quite easily, rather than trying to track down new data about everything. And in terms of who they are for, so although PCN managers and other health partners are a key audience through that neighbourhood health agenda, like any JSNA output, we also wanted them to be accessible to anyone who's got an interest in improving outcomes for residents of Herefordshire, so including commissioners, any decision makers across all council services, all partnership services, the voluntary sector, and any stakeholders, should be available to anybody. So I'll just go into a little bit more detail about the approach that we took on in the next couple of slides, but just to say that that proposed approach was endorsed by a range of groups across the whole system, and One Herefordshire Partnership agreed these neighbourhood areas, which I'm going to tell you a little bit more about now. Excuse me. So after deciding that we'd focus on area-based needs, we had two key questions to answer. What do we mean by a neighbourhood, and what do we mean by a profile? So starting with neighbourhoods, the National Neighbourhood Health Framework assumes populations of around 50,000 people for those kind of practical contracting decisions. And that's broadly similar to a primary care network. So that gives us that link with those footprints already. But they're not defined, and local areas are encouraged to use geographies that work for them. So Herefordshire presents some particular challenges. I think with our rural area in particular, most people would think of a neighbourhood as something much smaller than 50,000 residents, villages, parishes, or maybe even a few streets. And a common definition that we use in social science data is somewhere within a few minutes walk of home. So obviously we're talking about a much, much bigger area for those practical reasons. At the same time, different data sets describe different populations. So some are based on residents, thank you, while others are based on people who are registered with a GP. So that's a really key distinction between resident-based and registered populations. And then GP catchment areas overlap, particularly in Hereford City, where we've got two PCNs, HMG and WBC, providing services to almost the same population. So going back to that brief of understanding the characteristics of the areas, particularly the wider determinants affecting health outcomes, the key data sets that we wanted to focus on are about that resident population. So our areas needed to reflect the availability of that data. And we were quite lucky in that definitions and boundaries already existed for the 9 localities in Herefordshire, and work had already been done on defining PCN areas based on those localities. So the solution was to define 4 neighbourhood areas based on those and produce a profile for each. The 2 city PCNs are combined into one Hereford City neighbourhood area, because it would just be impossible to try and separate their populations when we're talking about population need, demographics, etc., etc. You'll also notice from the map that Tenbury is part of the North and West neighbourhood, and we incorporated as much information about Tenbury as we could, which was particularly welcomed by PCN managers in that area. But I think just the last important point on this one is that the profiles don't stop at that neighbourhood level. So I'll keep coming back to this as we go through. But we're not saying let's just understand this big geography. We're really wanting to try and understand what's going on within the area as well. So the next question was maybe a little bit simpler. So having defined the geography, the next question was what sort of profile would add most value? So we recognise that there are already lots of tools that provide data for small areas, so fingertips, ONS's Census Explorer, and lots of local tools as well, exploring healthcare, and then our own ward and PCN area profiles. But what they don't do generally is provide interpretation. So we decided that the emphasis for these new profiles should be on analysis and insight. And we wanted to triangulate the different pieces of evidence and try and tell the story of place and the areas within it, as I say. So we agreed on a written profile for each of the 4 neighbourhoods focused on the narrative and graphics, rather than listing all of the data points again, which are available in lots of different places. So hopefully that gives you a good understanding of the approach that we're taking with this developing work. I'm now going to move on to the findings that are starting to emerge from it. So in your agenda packs, you received the draft full profile for North and West as an example of that detailed product. As Zoe says, they're very long because it's pulling together so much information. But then there's also a first draft of the summary profiles for each of the 4 neighbourhoods. So there's one for North and West, one for Hereford City, one for South and West, and one for East. And that kind of second output of a summary was developed following feedback with stakeholders that we shared the full North and West profile with, who said, it's great, there's loads of stuff in there that we didn't necessarily know, but actually it's quite a lot to take in. It would be really helpful if you could kind of give us some of those really big messages to help us focus on what it's telling us. So yeah, those summaries distill all of that information into a set of key insights about each neighbourhood, which has been quite a challenging exercise, as you can imagine, I'm sure, trying to boil down all of that information into 5 or 6 key points that try and tell the story of that particular area. And you're the first group that we're sharing these drafts with, so we're quite looking forward to hearing your thoughts on whether we've kind of got the right balance afterwards when we've got time for discussion. So over the next 4 slides, I'm going to show you a set of headlines, and I'm not going to tell you which area they're about either. So as you read through them, I'll give you a little while to read through them. Have a think about which neighbourhood it feels like they might be describing. But it's not a test of local geography knowledge. It's a test of whether these drafts are successfully capturing the story of place that you might understand with your local insights. But yes, a quiz. So, if we look at these themes for the first area, what sort of area do you think these are describing? I'll just give you a few seconds. Yeah.
Hereford City.
It is Hereford City. First one, yay.
I think the Q is in Hereford's youngest population.
Absolutely, absolutely. And the role as a hub as well, creating those opportunities and challenges.
That's the clue.
Yes. So this is probably the easiest one to spot. We started with an easy one. So it's the most people in the smallest footprint. So obviously it's got the most densely populated of our PCN of our neighbourhood. Sorry. But I think the defining story of Hereford City isn't just that it's urban; it's a place of marked contrasts. So we probably all know that it's home to many of our most deprived areas, but it also includes some of the least deprived parts of the county sitting alongside them. So the two least deprived areas of Herefordshire are in North Hereford City, in Tupsley, in and around Tupsley. And we also see those inequalities, or those inequalities are reflected in health and wider outcomes. So, for example, men in parts of South Hereford can expect to live 5 years less than those elsewhere in the city. So that's the county-wide inequality in life expectancy, just in that really small footprint of the city. And then we also see it in the opportunities for prevention. So patients of Hereford City practices have higher smoking rates than elsewhere in the county. And there's more avoidable mortality than in other neighbourhoods in this one. So on to the second of the four. I want you to show the map again.
Yeah. It's not my area.
That's going to be the Ledbury Bromyard East.
It is.
Brilliant. And it's all my area.
So yeah, East presents quite a different picture to the city, and it's quite a tricky one because the overarching message is kind of one of positive outcomes. So higher life expectancy, better lifestyles, and really strong communities. So some of those kind of indicators of resident satisfaction really come out very strongly in East. So yeah, it covers that eastern border with Worcestershire, making it a relatively well-connected area for Herefordshire, particularly as it's the only one of our neighbourhoods with more than one railway station. And we see that in the distance that people are travelling to work. But then East is also a reminder that these area-wide averages can hide pockets of need. So within East, Bromyard Central is one of the 20% most deprived areas of England, and Ledbury Central is also amongst the most deprived locally. Both of those areas have relatively high rates of emergency hospital admissions, but there's also other areas that come up when looking at health needs, but also child and family need, for example. So it's not just about those kind of classic measures of multiple deprivation. There's other things going on as well, which is kind of why we need to be looking at those underneath that detail, at the detail underneath the big picture. So third out of four. Does this make you think of anywhere particularly? I'll go with the first answer. It's south and west. It is south and west.
Yeah, and it wasn't my area.
So south and west is probably the strongest example of how these neighbourhoods are very large areas that don't necessarily reflect real communities. So its defining story is that it's our most geographically diverse neighbourhood. So within one profile, we're talking about Ross, which is obviously one of our better connected locations with its access to the motorway. And it stretches right across to the most remote parts of the Golden Valley and the foothills of the Black Mountains. And that's why so many of those kind of later messages are about access, housing, and very different forms of need within one big geographic footprint. So Golden Valley contains some of our least deprived areas, but in terms of overall multiple deprivation. But residents are more likely to face barriers to accessing services, both physically and digitally, in that area. And they also have some of the highest housing related issues, such as risks of excess cold combined with fuel poverty. And then, as with East as well, health outcomes are generally good, but that the pocket of multiple deprivation in John Curl in Ross stands out with notable health challenges in that particular area. And then on to the last one.
This is my tiny rural Asian area.
I'll let you read those, Councillor Gandhi, and see whether
they're absolutely true.
I don't know why I've kept it hidden, really. I think that's probably music to our ears that we're hitting the right notes, definitely. So again, North and West really reinforces the importance of looking below those county-wide averages. As with East and South and West, overall outcomes are often good, but there's significant inequality concentrated in a small number of communities. And one of the things that really stands out in North and West is the extent to which the same communities in the middle of Leinster appear repeatedly across indicators of need. So children, families, working age population, and then that comes through in terms of their health outcomes as well. So I'm sure that that's familiar to most of you. But what might be a surprise is that in the latest indices of deprivation, which came out last year, Ridgemore and Grange are currently ranked as the two most deprived areas of Herefordshire. And Ridgemore is the only one of our local areas that's in the 10% most deprived nationally now.
The interesting thing about, compared to, I think, the others we've looked at, the north is very, very, very different to the west. And I don't think in the others that we've looked at that there's been such a stark difference between the two parts. So there's a lot on there that doesn't apply in any way to the north, but does to the south, and vice versa.
Yeah, that the second point I was going to make is it was a bit of a surprise to me at just how rural North and West really is when we looked at the domains of the geographical barriers to services. So yes, Black Mountains in South and West is the most remote, but 6 of the top 10 areas for geographical barriers to services are in North and West.
And they're nearly all in North.
Yes, yeah, literally in the North and West, aren't they? And I don't think we would have appreciated that if we hadn't have started looking at this data kind of through this lens as well. So it's been really interesting, even with really familiar data to all of us. It's about how we're looking at it differently.
I think it's music to Councillor Gandhi's ears, so we'll let her have a word. Can you use your mic, please?
Sorry. We had Sir Chris Whitty come to visit Herefordshire 9 months ago, I think. Before Christmas. And we chatted to him first of all, and then we took him up to Ledbury Rugby Club, where he met a large number of voluntary sector organisations. And when we came back, he said, I don't have any power, but I do have influence. And at the present moment, the owning of a car takes you out of the deprivation area. And yet, having looked and talked to people
who operate in very rural areas where there is no buses at all. So her car is a must, even if a washing machine can't be had or a spin dryer. He said, my influence would be you need to take out of your basket the car and put something else in, because in some parts, in all over the country, this will be in rural areas, the car is an essential, and because we don't look like that when they're putting the funding together for local authorities, we miss out, and we shouldn't do.
So just thank you for all your contributions. That's it's really nice to hear that they're kind of getting there in terms of the story that they're telling. But just to reflect on the process of developing them, 3 lessons really stand out, and I think I've probably covered most of them already. So firstly, that overarching Herefordshire story remains important, but that each neighbourhood has got its own story. You'll have noticed that some themes were similar across the 4 neighbourhoods. And I think it's worth emphasising that this wasn't about trying to compare all 4 neighbourhoods. I found myself kind of, when I go over them, I'm kind of, oh, there's a lot of similarity there, or why are we saying that about that one, but we're not saying it about that one. But it wasn't about trying to create completely unique stories, because those issues are all appearing in different ways across Herefordshire. But those key messages reflect the themes that stood out most strongly when we considered each neighbourhood in its own context. So I think we probably all thought that when we started developing these key findings, we'd be talking about a built-up area with pockets of deprivation, where needs concentrated, surrounded by that rural hinterland. But whilst there's an element of that, of course, because that's the nature of Herefordshire, there's subtle differences that help identify what the real challenges in those areas are. So it's really reassuring that you picked up on those and that they are working. Then secondly, that really coming back to that point that we set ourselves in the brief, that variation within neighbourhoods is probably more important than variation between the neighbourhoods. This isn't just about how does East compare to North and West, because when you look at the 4 of them as a whole, that when you're just looking at PCN averages, there isn't that much of a difference. But it really, really comes out when you look at those urban-rural distinctions and then the pockets of need within those neighbourhood footprints as well. And then the third point, as I said, looking at familiar data through that lens of a neighbourhood helps ground our local knowledge in evidence, reveal new insights and give us some surprises, but kind of not doing necessarily revolutionary things with data, and it's familiar data to all of us, but it's looking at it from a different angle and learning new things from that, and giving us that shared evidence base for our local understanding as well. So then one example of that final point comes from work on digital exclusion in Leinster. So this is some data that is included in the profiles. There's a new National Digital Exclusion Risk Atlas tool, and it identifies Leinster Grange as being the highest risk of digital exclusion in Herefordshire. And this was noted by a GP who was keen to explore what that means for inequalities in access to healthcare in the area. What was particularly interesting was that this isn't an issue of broadband access, it's an issue of skills and confidence in using the internet. But then again, coming back to that kind of not necessarily needing to do new analysis all of the time and kind of drawing on what do we already know, we asked ourselves 2 questions. So what do we already know about people in Herefordshire who are at risk of digital exclusion? And what else do we know about the people of Grange? So the JSNA summary tells us that certain groups are less likely to use the internet or be concerned about more things moving online. And there's a really strong link with deprivation, and particularly with social renting. Then looking at what we know about Grange, there's lots of overlap. So as I said, it's the second most deprived area overall in Herefordshire, particularly affecting working age people. So there is a slight difference within Leinster, that Grange is sort of working age inequality, and Ridgemore and Gateway are sort of family and child issues. Within Grange, there's also some pockets where there are high levels of renting, social renting and private renting. So looking at the data in that way for that one specific area has provided wider context and helped identify opportunities for targeted action. So that's really the sort of iterative, collaborative and place-based use of intelligence that we hope these profiles will support as well as we roll them out further. That's the end of my section. I'm now going to hand over to Badri to summarise everything and
Thank you, Charlotte. Very good afternoon, councillors. We're pleased to hear that we're almost end of the presentation now, just a couple of slides to go. So I just want to summarize, but hearing the presentation and your response, what heartened me was that it is speaking to you as a local elected, you represent the community and you're able to identify, you can see the pattern. So that itself shows that we are not got there yet, but we are probably getting there. So the neighborhood health approach is very fundamental for prevention and also to make people stay independent and moving care closer to home. Those are three key objectives. And that's why understanding the neighborhood will really help us in meeting those objectives. And it actually, the neighborhood profile is nothing new, but it provides a tool for us to take interventions or at the neighborhood level, which is what the intention of the government as well. Local players coming together, understanding at the very local level what we can do. And this is one of the, JSNA is an ongoing process, and this is one of the newest addition to our JSNA toolkit. And as Charlotte was saying, 50,000 is a national guidance, maybe slightly bigger for us, but we have got other profiles we can look at a very small level, GP profile, ward profile. If you want to go further, drill down, we can drill down to more lower levels. Yeah, next slide, please, if you want to move. Just one more, I think. So the profiles, the objective of this profile is to inform all the partners, provide them that evidence base at the local level, what action they can take, identify priorities, identify needs, and make sure there are appropriate interventions. So that is the main objective of the profile. And as Charlotte said, this is the earliest version. We just got it now, and you are the first committee because it's not gone out. We have not we've done a little bit of a iteration, but nothing much. And then the other three profiles are in development. So just the next steps are we want to develop the full profiles, and then we will be sharing it with wider stakeholders, and then we will refine it. What else will be helpful to make it, any changes we need to make. And also we will be able to add anything that comes along, for example, falls. There is a lot of information analysis being done at falls at a local level, so we can add falls to this as well. So this is again, will be iterative process as we'll be keeping it, adding things as they come along. So the final slide, just your thoughts. It will be helpful for your reflection. So I know we are here to answer your questions, but also it will be helpful for us to have a bit of a reflection of the committee. Do the profiles tell a meaningful story about the neighborhood? That's the first question. Is it really telling a story? And what might improve future iteration? Do you think anything else we need to add? What are your thoughts on those so that we can do it better? And also, in your expert view, will these profiles best support neighborhood health decision making and also scrutiny, which is one of your main role? Thank you.
Thank you, Badri, and also Charlotte. Oh gosh, Charlotte, you and your data, it's just mind blowing, isn't it? And I must admit, I know it's about me, and it's a bit like me in numbers. I used to do accountancy, and if it's numbers, I love it. But we've got to expand our minds. But for me, I felt I was being a bit selfish because I was really focused in on my ward, which is northwest. It's the Queenswood area, and I was looking at under that sort of lens. But I know Councillor Bartlett would have loved this because she's Leinster, and she would have really appreciated all those concerns that are really raised for our county. I think it's a really good concept doing them in these profile ways, because yes, you can get the whole picture of the county, but you can also then drill down to those other details that perhaps get overlooked if you're not specifically going into an area. I don't think some of the things were a surprise to some of us. You know, we know about Hereford City has areas of deprivation, and also the Leinster area. So yeah, crikey, it's a huge piece of work, and really, really interesting to look at. So can I just ask, before we move on, Councillor Davis, is that all right? What are the three biggest challenges or changes in Herefordshire's health needs since the previous JSNA? Because we're into 2 years now of the old one, aren't we? So, you know, I also appreciate that these things change every month, probably, never mind years. But what are the three biggest changes?
Yeah, and I would say things change slowly as well, though. You know, if you look back sort of 10, 20 years, and it's those slow changes of demographics, rising need in terms of our population, that actually almost can creep up on you. And that's where I think data is really powerful, because it gives you the hard facts, doesn't it? And I'm really glad there aren't any surprises on these, and that you recognise the areas, and that's what we would want. And I think when you read all 60 odd pages of the detailed profile, there shouldn't be any surprises in there. But we do plan to use these with a range of stakeholders, very much in terms of being data driven on that neighbourhood health approach. So coming back to your question around the top three changes, again, nothing that's rocket science here that's going to surprise you. I would say, you know, we've got an ageing population. Actually, that doesn't surprise us. But when then you look at the data and you look at it as Herefordshire wide,
Can I just say, everybody's got an aging population. What I would like to say, we've got a higher than national average of over 65s and definitely over 80s.
I think what's really interesting is that actually our life expectancy is stalling. So where we were better than national in terms of living longer in the county, and I'm doing this as very county-wide, but recognise that actually it's the neighbourhood profiles that we would want to look at the detail and the inequalities. So we were better, and that's really started to stall. So actually England average has caught us up, and now actually we're comparable with England average. So again, I think sometimes it masks, you know, where we compare with the national average. It's the inequalities bit, that gap in life expectancy, and also the healthy life expectancy. So what's changed? Actually, healthy life expectancy has gone down. So I think that's something we really need to have our eye on, because if you've got life expectancy slightly going up or remaining fairly static, but actually healthy life expectancy is lower, then actually that gap is wider. And I'm sure none of us want to be living that final 20 years not in very good health and well-being. So that really is a wake-up call for us in terms of our population. And then the bit around the differences, because all of that masks the differences in our population. We quote those figures as, you know, the 5-year gap in healthy life expectancy or what have you. But actually it's, as Charlotte's just presented, the really stark differences even within those profiles. And that's where this becomes really powerful, to go, at least start asking the questions then of, well, why is that difference and what's driving that? And back to the beginning of the presentation in terms of those building blocks. And so I would say not all of it's quick. Some of that really has been 20 years in the making, and we're seeing some of it now. So aging population, over and above average, you know, that healthy life expectancy stalling, the inequalities in it, and what comes with that, and again, this is a national picture of the more complex long-term conditions, and that does have an impact on us in terms of health and care needs, and how we plan for those health and care needs, and how also we need to plan around not just seeing a condition, but recognising that people are living with multiple conditions, and what do services look like in a really rural county, and how do we deliver better those services that aren't just condition specific. So that's quite a lot in there.
One of our things is immunisation, isn't it?
Yes, thank you, Councillor Gandy. So in terms of where some of our priorities are, so we've looked at prevention priorities, and the three we're really wanting to focus on are around smoking, so that we know that the impact that that has in terms of cardiovascular disease, immunisations, as Councillor Gandy just said. So we've looked at where we remain red on an indicator, where we perform worse than the England average, and where actually trend is really hard to shift. And the other one that Badri mentioned in terms of falls. So there are three prevention priorities that across the county that we could make really rapid progress on, where we know that actually if as a system we drove hard on those, we would make an impact in terms of health and care needs. And then I think there's a job at neighbourhood level to then say, well, they're three county-wide priorities, but at each of these neighbourhoods, what does that mean to that neighbourhood, and how do we design services around that for prevention?
Thank you, Zoe. That's a really a lot of food for thought. You mentioned smoking. I don't know what our smoking cessation levels are at now, but I know when I worked at Wye Valley Trust, I worked in the midwifery area, and they had a smoking cessation midwife. And the proof of the pudding there was in the eating, because she got those levels really down to hardly anything, and that role stopped and they've gone back up. So, it does prove that if you've got somebody leading in a high profile area, then you can make a difference. And Badri,
I think there's something we're going to do a bit of work on. So I think we're going to do a bit of work on. I mean, I smoked through both my pregnancies, so there we go. But that was many, many, many years ago, and I've paid the price for it. But we only measure it for a certain period of time, and what we don't know, and what we should be measuring, is how long that person post birth no longer smokes. Do they give up forever, and that's success? Do they only give up for 3 or 4 months, or while they're breastfeeding or whatever, and then they go back to smoking again? And we don't have that information. It's not easy to get, but it's important.
Yeah, I totally agree. But also, in terms of the smoking prevalence, how that's a real success story. So you ask what's changed in terms of our population. Well, we know that the under 75 mortality rate from cardiovascular disease has come down significantly over the last 20 years. That's nationally as well as for us. And we clearly know that one of the driving factors of that is obviously the relationship with smoking. There are 7 modifiable factors that drive that, and one of them smoking. We've seen real success at that. So around 10% in terms of smoking prevalence. We need to get that down by 2030 to under 5%. We're on track to do that. We should achieve that. But actually what's interesting with the neighbourhood profiles then is when we actually delve into that in terms of the differences between our areas. They're the questions we should be asking, instead of going, well, we'll accept actually we'll get it to under 5%, or that actually we'll get the number of pregnant women that are smoking down. I totally agree with you. It's do they go back to smoking, and let's track that. But also when you look at the difference between general population who smoke and routine and manual workers as well. And we've seen a reduction in that, but we need to work really hard to reduce that further. So actually, we don't mask it by saying 10% prevalence of smoking, we should reach our less than 5% target, but we really think about the inequalities in the routine manual workers.
yeah, it's a much bigger picture on everything. And I think what Badri mentioned about falls, I think because we've got this higher than national average or thereabouts of older people, we don't do enough for osteoporosis, etc. We don't do enough through Wye Valley, perhaps with educating people. If you're a woman over 40, you should take a supplement, vitamin D supplement. And, you know, it's just getting those words out there. You know, I had 2 falls in 2 years and broke bones. And it wasn't till then that the team came in and said, why aren't you taking vitamin D? I didn't know I was supposed to.
And falls is one of our prevention priorities for the very reason in terms of good evidence base about what we can do with it, very good return on investment, and certainly very good in terms of how we early identify those at risk and intervene early. So there's a newly established falls network that's chaired by someone from adult social care and by David Collier, who's the consultant in public health. They co-chair that. That's had its first meeting a couple of weeks ago and is very much looking in terms of partnership, what we do around falls prevention for the county.
Good. A little too late for me, but you know, I've got rock hard bones now because I'm on all sorts of supplements. Councillor Davis and then Councillor Tully.
Thank you, Chair. I'd like to ask a question on the breakup of the county. And when I say breakup, what I mean is the demarcation of East, City, South, and the North, Northwest, Southwest. What was the decision that drove that particular design feature? Because with the stipulation of having 30 to 50,000 people per PCN, there could have been 6 areas. I mean, that would have made a lot more work if you had 6 areas than 4, but potentially. But could you just explain a bit more of why that decision was made?
Certainly, and then I'll hand to Charlotte, who's probably got a bit more of the history than I have. So these are fairly long-standing primary care network areas, the 5 primary care networks, and Charlotte touched upon. We've got the 2 Hereford City ones, which, to be very pragmatic, joined those together, so we've got the 4 profiles. These are very much mapped to where neighbourhood health is being designed around. We recognise that actually these are fairly arbitrary boundaries around it, which is, I think, what you're getting at. And therefore, when we're doing the profiles, we're saying actually, even though the line is drawn around here because that matches health's profile, health's boundaries of where they're thinking in terms of primary care, that actually we'll do that for pragmatic reasons, but we do need to delve below that to more of a granular detail to really understand the differences within those, because they're huge areas. And clearly, like Charlotte's articulated, there are, you know, massive differences within those areas as well. I don't know if there's anything you want to add, Charlotte.
I don't think there is. I think it's, as Zoe said, it's the pragmatic application to the PCN areas and really these being a useful resource for that neighbourhood health work, which is driven at PCN level in particular. So yeah, I guess just to add that the 9 localities that we have been around for sort of, well, the localities themselves have probably been around forever, but as boundaries, they've been around for maybe 15 or so years. I don't think they change substantially over time. I think they're probably quite meaningful to most people. They were evidence-based when they were designed. I think there's an element probably of being, again, that word pragmatic about where the lines are. So within the profiles, we're talking about sometimes resident population, sometimes registered population, sometimes data sets don't quite align to those dotted lines within the localities, but it's generally about the experiences of people in those areas.
Councillor Tully.
Okay, I'm going to try and keep it really clear, but I have got a few thoughts and a few questions. 2 thoughts, one about the shape of the profiles. So, oh, yeah, sorry, I thought that was me that I had pressed my button. So, yeah, one thought on the shape of the profiles. It just felt to me that, again, in each area, there's such a difference between the market towns and the rural. And even in our rural county, we're still kind of choosing areas that include market towns and rural areas that seem to have such different profiles, and the city. And I just wonder, you've always got to cut a cake a certain way, but I just wonder whether there's ever and whether with the prevalence of being able to look at data differently now with such kind of moves into being able to be a bit more clever with how we look at data, whether sometimes we could just say that we would look at the cake in terms of the number of the population, or looking at all the market towns. Like, if you imagine, it's awful, it'd be awful to make a map of it and really difficult, but all the market towns and all the rural areas as opposed to the shape of those. And that's just my thought on when you first see. But it's interesting because it's also very helpful to look at the market town and the things that come outside of it as well in terms of other things. Are you going to come back? I'm nowhere near finished my thoughts, and so please do.
Shall I come back rather than
Yeah,
list?
yeah,
Is
yeah.
that easier?
I mean, it's just a thought, so yeah.
It's very helpful thought, and you're completely right. You know, we know those differences, don't we, in terms of urban, rural split and what have you. I think bringing us back to purpose of these, that actually we know that the drive around neighbourhood health, and that is looking at these footprints so actually being really sensible and clever with, actually this is a resource that can be used in those footprints to really think about what does that mean to design service provision around that population. But I think you're right of making sure in the profiles we're really differentiating between the rural urban split. We have some further work, for example, the cardiovascular needs assessment that I mentioned earlier, that really has done that, of gone, actually, what is the difference in terms of deprivation, and also what's the difference between rural and urban as well, in terms of admissions and mortality. So I think that makes a really interesting read that we're very happy to share with you. It's due to be published, but very much the purpose of these around neighbourhood health, and how do we use these to be data informed around neighbourhood health.
We could have scripted this because I've got a question on that, so that's lovely. The other thought that I had was just around how useful the information is for the conversation about transport as well, with everything that you were saying to do with cars and having a car, and that it really helps with us and in how we discuss locally about the need of public transport and what it could avoid in future, how it could lead to a neighbourhood health plan that actually people can access, and also how we argue nationally about that in terms of our access to that. So thank you for that. So I think it's helpful. That's just a thought. So then the first question I had was about neighbourhood health. Lots of people have said, when we've been talking about social care and the Task and Finish group around that we don't lack data. We lack the ability to analyse all of that data, and we don't lack data, but then of course there's loads of different agencies. So I just wondered how this is going to feed into the neighbourhood health plan, and what the timescale of that, in terms of that. There's a plan, and I believe it's in our court, and so what the timescale of that, and just a note from talking to a project in Norfolk to do with falls prevention. So it's really good to see that falls prevention's on it, and the conversation with Norfolk about their falls prevention. The whole reason we had that conversation was because they had this great way of looking at data that was all about, talk to Norfolk, it's all about AI. And when we talked to them, it started with a really good way of looking at data, really good way of pulling the data from so many different places, and looking at the potential of, so that we could really prevent, so that they could actually. And then after that, it was nothing to do with data. It was to do with how our services work together. So I wonder where we are at using this for the neighbourhood health plan.
Yes, certainly. So neighbourhood health, I think we've taken as a fairly county-wide approach at the moment. So any progress has been county-wide with some smaller scale pilots. Very much the design of this is to generate those conversations at primary care level, to say, hey, this is what the neighbourhood looks like and the differences within that neighbourhood. And actually we've got these prevention priorities that are county-wide. But on top of that, what's important to this neighbourhood? And it's to start that conversation. I'm in total agreement. Actually, this is a product to start the conversation, and then after that, it's the success will be in terms of what is planned out of it. This is a starting point.
Sorry, I've got more. So there's two more, and maybe this is just to like note it and then beyond. But you said that the One Herefordshire Partnership agreed the neighbourhood areas. I would love to know when and where that was agreed and recorded, because I'm finding it a real struggle to understand where the One Herefordshire Partnership is noted, um, uh, uh, who's on it, and how it gets recorded, what its efficacy is, and what it is doing, because I've had real struggles getting that information. So it's great that they agreed this, but and how is that going to be? And I'll just move on with the last one, which is that you also mentioned that one of the next steps could be about working with social landlords. So I think it's great. It's registered social landlords' actual legal obligation to work with agencies around building the communities in their area. And so I think it said on your slide outreach via social landlords, but I'm interested to know how this work might encourage them to do the thing that is legally what they're obliged to do as well. Thank you.
Okay, so I'll leave Charlotte in terms of the social landlord one, because that was on one of your slides. Coming back around the One Herefordshire Partnership, I'm sure we can share the terms of reference around that. I can find where it was, the decision was made in terms of One Herefordshire Partnership. And like I said, I think there was a fairly pragmatic view there in terms of primary care networks already exist, those footprints. We're not unique in terms of following those footprints for our neighbourhood health plans, like lots of other areas are. Not all areas, but lots of other areas have gone down that route because there was something that already existed in terms of planning health at a more localised level than county-wide. But I can certainly confirm that information of when the decision was made. And the One Herefordshire Partnership and Neighbourhood Health then feeds into Health and Wellbeing Board as well, so she'll be reporting into that in terms of neighbourhood health plans.
Councillor Andrews.
It's all right. Well, thank you for that. I find it extremely interesting. It's the most interesting reading. It really is. I bring it down to a more personal level now. I represent an inner city ward. You're actually sitting in it as we speak. So it's a real mixture. But one of the main two problems, I think, one is that it's an awful lot of bed sits and rented houses, HMOs, with a lot of people of ethnic backgrounds and Eastern Europeans. And particularly you mentioned smoking. They tend to be much heavier smokers for a start. And Eastern Europeans. So you need to, if you want to get smoking down, you need to put out information in their languages, not just English. Yes. And secondly, I think the other problem too, from my own observations as I go around, is obesity, which you don't seem to have mentioned. But that really is an increasing problem. And also, I think on mental health, just as an aside, the increasing numbers of people with dementia.
Thank you. And you've mentioned, some of the top priorities in terms of we know the things that we're persistently red for. So in terms of late diagnosis for dementia, we know that and doing some work around that. I guess all I focused on is you asked for the sort of top three. They're not necessarily the ones that we've performed the worst for. Again, they're ones that actually we've picked three prevention priorities that are county-wide in terms of neighbourhood health. That's not to say that obesity isn't a priority for us. We know in terms of what that looks like for our population, and lots of work going on in terms of the healthy weight pathway and what that looks like and where there's gaps in that. And we know in terms of dementia for our population, late diagnosis of dementia. I've purely picked out three that we're driving forward through neighbourhood health that will change over time, and we'll pick another three, but actually they're three where fairly quick wins in terms of good evidence base, low cost. We can do stuff about falls and vaccination and smoking pretty quickly and should see some progress within 12 to 24 months on those. So that's why they're picked. Obesity, dementia diagnosis, longer term, but definitely priorities and definitely worth tackling.
Thank you very much, Zoe. I'd just like to welcome Hilary. She's just arrived on the virtual screen, so Welcome, Hilary. We won't keep you many more minutes, but thanks for attending. Okay, so any further questions, comments, or concerns from committee? No. Oh, Councillor Thomas.
I was just looking at the map for South and West Herefordshire, and you've got most deprived in Herefordshire being, well, it's Madley, Monington, Bredwardine. I know those areas, it's just outside my ward, but I would disagree unless you put purely on transport, because there wouldn't be much of a bus service in that area, I must admit. But why would you? Certainly, there aren't any areas of deprivation as regards large conservations, council houses, what used to be, and things like that. I just wondered why.
Thank you. So I don't think that map's in. Is that map in the presentation, or are you looking at the appendices? But so the index of multiple deprivation is a nationally produced data set which has been around for 20 or so years, that ranks lowest deprived areas on 7 different types of deprivation. So barriers to access to services is included in there, as are kind of more people-based indicators such as income, employment, education and skills. So those maps represent those national rankings. If it's I think you said it's one of the most deprived in Herefordshire, so it's just kind of showing that gradient of deprivation. So I don't think it's amongst our most deprived, but it's possibly slightly more deprived than other areas. Does that help answer the question?
Thank you, Charlotte. One of my questions was alongside Councillor Tully regarding how will the JSNA directly influence housing, and she did mention housing in her questions. Is there anything that you can take from your profiles to support housing?
Should I just refer back to your question about?
Yeah, it was on the slide when it said next steps, outreach via, and just how you're working at every level really with those housing associations to make sure that that they have the knowledge to do the job that they need to do, as well as us doing it.
So I think that particular question was about the case study around digital exclusion in Leinster. And that was a piece of work that a GP has picked up on and is leading. So it's very early stages. So that analysis is kind of signposted. Maybe these are some kind of opportunities. So it's kind of that collaborative approach. So I don't know where we are with it at the moment. In terms of sort of the wider JSNA, I don't know, so if you want to come in, but it's about making it as accessible and as available to everybody, I think.
I agree, and I think we've done quite a job before with the general sort of JSNA in terms of making sure that stakeholders are aware of it and how to use it. I think, like I said, you're getting a very early sight of these, which is great. The first step is to share those at a primary care network level in terms of informing neighbourhood health, but then there's a whole load of steps beyond that, isn't there, in terms of who else we want to engage with that as a resource that's at that footprint as well.
But just don't make it so big that it gets lost. Okay, so any other comments? Councillor Gandhi, is there anything you want to say or not? No, you're okay. And officers are okay as well. So again, thank you very much for that presentation. Yeah, very interesting, and obviously it met the objectives for us, which was to review the work to develop the neighbourhood profiles as part of the JSNA framework for Herefordshire. So yes, thank you very much, and we'll watch your journey now, won't we? Because it's the beginning of a big journey. Thank you. Okay, so we'll move on now to item 9 on the agenda, which is the adult social care budget outturn. And like I mentioned briefly, we've got the Director for Community Wellbeing, who is going to talk us through the budget outturn and where we are. Welcome again, Hilary. Thank you very much for attending. And I think, sorry, I think Zoe's staying as well to support. Yeah. Thank you.
Thank you, Chair. So if I give you a bit of a verbal update, as you'll be aware, the 2025-26 revenue budget outturn for community wellbeing was a net overspend of 3.7 million. That was after the application of a contribution from the Budget Resilience Reserve. That included 0.9 million of undelivered savings, but the primary amount of the overspend was due to increased demand across all forms of adult social care, particularly focused on domiciliary care, residential and nursing, and a sizable proportion of that as a result of people leaving hospital with increased needs. What we saw, whilst you would always expect to see a greater increase in demand in the first half of the year, what we saw last year was a really significant increase in people needing formal care and support in that first half of the year, and that was only partially offset by a reduction in demand in the second half of the year. So that was the position going into this year. The budget was set accordingly. We're yet to report formally on Q1 for this year, but we are seeing positive signs of our focus on managing demand. So looking at weekly figures, and that demand is broadly in line with the budget that was set for us this year. We'd expect the demand to be slightly higher in the first half of the year. That's, as I've said, that's very common. And then it tails off over the winter, but we're certainly not seeing the levels we experienced last year. And I think that's a real positive step forward. And we are seeing a greater focus on supporting people with care in their home and supported living. So trying not always to rely on residential and nursing care. In terms of the savings, we're well underway on delivering this year's savings. And as you know, we're expected to deliver around 7.3 million. The savings that we expected to be delivered in the first quarter, because we've profiled them, they have been delivered. And I know that as a committee, you've received a briefing on the largest area of our savings programme, which is around care home partnerships. Pleased to say that the work is continuing on the undelivered savings from last year, and they have already reduced by 300,000. So that is, we are keeping a clear focus on that. I think just by way of reassurance, Chair, we have a structured and robust process for budget oversight and savings delivery, and that's dedicated work streams and then oversight and challenge at monthly meetings, which involve our directorate leadership team, finance colleagues and our cabinet member. We're very aware that we are managing both, as you will know from the Scrutiny Management Board session, we're managing a big transformation programme, an improvement programme driven by the CQC inspection, as well as savings delivery. And we have put in place what I would consider our robust processes for managing that. Very happy to answer any questions, Chair.
Thank you very much, Hilary. I don't want to get too excited because it's still early days, isn't it? But you know, credit where it's due. And rather than concentrating solely on overspends, can you explain if the expenditure is delivering better outcomes?
Yes, I believe it is. So we are working with people so that they can remain in their own home or in supported living. That's not to say they won't get good outcomes where they need it in residential and nursing, but it is trying to deliver care to people in the environment which works best for them and where they feel most comfortable and secure. And I think it is. We have what we refer to as our people's voice, which is a survey that we send out after every interaction with anybody in terms of an assessment and a support plan, and that's about gauging their opinion on how well have we dealt with them, you know, lessons that we can learn from that, how can we do better, as well as celebrating any strengths from that. So we keep that kind of impact measure is really important for us, and we can continue to collect that. And you'll see that it forms part of the impact measures for our improvement plan as well.
And there's nothing better than talking to the people who are actually using the service, and not just talking to them, but acting on what they're telling us. And I think we all understand that complexities are increasing. So, you know, this is just something we just have to keep on the ball with, and make sure we're trying to keep one step ahead of the game. Councillor Davis.
Thank you, Chair. Can I ask a question? How do we monitor, bear in mind we get the feedback from these surveys with all interactions, if we have care providers given to people in their homes who are providing that level of care, do we get feedback on their care provision?
In simple terms, yes, we do. And we also have our own quality and review team who will do spot checks and will talk with the provider as well and talk to the people for whom they are providing care and support. Where we have situations where we have major, a number of safeguarding concerns are raised in relation perhaps to a particular provider, then we will do a concerted work across safeguarding and our quality team so that we're looking both at the individuals and the provider to ensure that we address those in a timely way. But on an ongoing basis, we will get that feedback from people in terms of that provision in their own home.
Thank you.
Anybody else? Councillor Andrews?
Thank you for that, Hilary. Just a comment. I mean, we were lucky, I think, this year. It was a comparatively mild winter. We didn't have people falling over quite so much. And
there was a big flu outbreak.
Pardon?
It wasn't. There was a big
But
wasn't. It was the weather was all right, but we had an epidemic of flu.
Yes, but even so, it was a mild winter in the sense we didn't have the bad weather that we often get. Just a query: I know there's always been a problem in the past. The number of people who are in care who are self-funders, who get to the limit of that, and then we have to take over their care. How much has that been costing us?
So there has been an impact on the budget. We usually somewhere around £500,000 will have an impact on our budget. We do try and structure that within our budget setting because we anticipate that there will be people that fall below the capital threshold. What we're trying to do is put in place, so through our transformation and improvement work, is improve the offer that we give to self-funders, so we get earlier notice of people who are self-funding, and then as their assets decline, if you like, that we get that early warning. I think some of the issues that have arisen, certainly in past budgets and as we know, is when that happens very quickly. We're not aware of it. I mean, we're not required to be told about it, which is one of the probably not helpful. So by improving our offer for self-funders, hopefully we get that early warning. It just helps us to plan, do those timely assessments and make sure that we're on top of it so the providers are not out of pocket, and we would always work to ensure that. But equally that people are assured that their care will continue. A lot of people will see it as falling into debt if they can't pay their care home fees or care fees. And we're keen to kind of work with people to assure them that isn't the case and that we have those processes in place.
Is the NHS still being as awkward over continuing healthcare as it was in the past?
Continuing healthcare remains an area where we have active debate and negotiation.
And ultimately, it's the Integrated Care Board that actually funds any continuing healthcare, and it is extremely difficult to even get anywhere near it. Yeah, very difficult. The other thing you talked about self-funders. I think people need to be reminded that there is no law to say that you can use your relatives' assets for yourself, and you can change them to you. There is this weird understanding that if you've not owned something for 7 years, then it doesn't count. Well, that doesn't actually apply. That's not the law. But I think people do misunderstand where they can and cannot use their or give their say property or money to a loved one. It's called disposal of assets, and you cannot do that if that's going to stop you paying for your own care costs ultimately. It's
transfer your house to your family.
no.
Still live in it. You have to pay.
No, it's a huge area that is quite difficult to navigate around the law. But Councillor Gandhi, is there anything you want to say?
Just a minor thing, really. So, one of the things that I was concerned about was the fact that I didn't think that our tech stuff was being as widely promoted as it could be. And so I spoke to Hilary and said, if I spoke to Sarah Shingler, would it be all right if I suggested that we had a stand in one of the, well, I wanted to go into the acute hospital, but into one of the community hospitals. And Sarah said, Hilary said yes, and Sarah said yes. So we did Leominster, and it was very successful. I mean, we wait to see whether people come forward and actually purchase the equipment, but we did have, while I was there, the matron or whoever it is that's in charge at Leominster actually speak to the member of staff and say, would you mind staying on and giving a talk to the staff at Leominster Hospital so that they know, so that they can talk to patients. We've now done Bromyard as well. We're about to do Ledbury, and lo and behold, we're doing the acute unit on the 7th of August. So we're going to go into the cafeteria in the acute unit and do a similar sort of thing. And hopefully, I mean, there would be a little bit of income coming back from obviously purchase, but it's more about the prevention side, and it's trying to, particularly in the community hospitals, trying to explain and to be fair, the officer who's doing this is very good at doing that. Try to explain that just because you don't live on the doorstep of your loved one, they don't have to go into a home. There is equipment that can be used that will keep them relatively safe.
Okay, Councillor Tully.
Just a quick question, Councillor Gandhi, around that. That sounds really great. And you said that we'll wait to see what that brings. Obviously, there's that's spread across quite a lot of the county. Is it Mark that you were talking about? That, and I've spoken to him, and he's a real passionate advocate of so many of these devices and so many of the possibilities. What I said to him, and I would ask you now, is so what does that look like, the waiting and seeing? How do we see the outcomes of that work? Because I think what I would be really interested to know is what you are doing to show very clearly that a conversation with somebody in a community hospital is going to lead to somebody not being in some kind of care situation that they otherwise would have been, and that is what other people are asking. That's what they're asking in different scrutiny groups where they're looking much more at the money. What robust work is being done in order to evidence the outcomes that enable us to put more trust and investment into the tech?
Some people that he has spoken to have already paid for some equipment. Most people sign a form with their a name and address and a telephone number, and he gives them a card and they can contact him direct. In some cases, it will be nursing staff advising patients that this is available, and in some cases it will obviously be residents, particularly ones that live a long way away, saying, I've seen this piece of equipment, which I think would be really good, and it'd be much better than going into a care home. Let's give it a try. I think it's not big. It's not big stuff. I don't think. I don't think at the moment, not because we're not offering at the moment any of the big stuff that we've got, which is for more for people with disabilities. We can't carry that around. So this is only small stuff, and it may only result in, I don't know, a dozen or so people taking us up on this. But if a dozen people take it up, and we get a small bit of income back, and a dozen people who have a fall, and are able to call somebody through not going to the hospital, then I think that's a good thing. So Mark, as you say, is a bit like the Duracell bunny, and at times he does get very enthusiastic about this, but it was interesting. I haven't been to Bromley or the Ledbury one. I did go to Leominster, and I will go to the county hospital. But it was really interesting how interested the staff were about the equipment, and the fact that they didn't know about the equipment.
Again, it's communication, isn't it? So
It is, and if it works, and we don't know, but if it works, then there are other opportunities where there are elderly people or people with disabilities where we could show this equipment and possibly get more people using that equipment, which will stop them. It won't probably stop them forever from going into care, but it may delay it for a year or two.
Thank you. Hilary.
Yeah, I was just going to say at a very pragmatic level, whenever anyone rings up or responds back to one of those roadshows, it's marked on the referral form. So we ask, where did you hear about this? So where did you hear about this? So we can start to track where where people have heard about something, be it from a friend, be it from Ross Hospital or the acute or wherever. Because I think the other part of this is not so much always, it is about savings, but it's also about cost avoidance. So if we can determine that we've managed to ensure that someone has not needed more formal adult social care support because of the tech that has been put in for them, then we can start to build a really quite good evidence base for what works and what doesn't for particular conditions, for particular cohorts. So just to reassure you, that work is ongoing, and that, at that very pragmatic level, we are collecting it as part of that initial referral.
Thank you, Hilary. That's exactly what I was asking, so really appreciate that. Thank you.
Yeah, I sprung this upon Hilary, and I didn't know what they were doing with it. It's only been going a couple of weeks, hasn't it, Hilary? So I didn't know whether that they put it on the referral form, because I as I say, I just sprung it on as an idea, and we just went with it. And
Thank you to you both. The purpose of this was just to get the verbal update on the budget outturn. I think we've had that, and I don't think anybody has got any further comments on that. Oh, yes, we have. It's Councillor Thomas.
I have got a comment, not a question, and I am actually very slow to praise, but I think adult social services has really turned the corner, and I really do think you're doing a grand job. Keep it up.
thank you very much.
Yes, absolutely. Thank you, Richard. Okay, well, thanks again, Hilary, for attending. There's nothing that we need to make any notes of for you to address, so we'll see you in the future. Thank you very much.
Thank you.
Okay, so everyone, we're on to item 10 on the agenda, the work programme.
Thank you, Chair. We march ever closer to your elections next year. We still have a few meetings to fill. a packed agenda for you. I'm pleased to say. We propose to look at Right Care, Right Place in September. We've sort of bounced this along now for a little while, so we propose to bring an update for you on that. We hope to have the final report from the Meeting Demand for Adult Social Care Task and Finish group. That may be delayed. I must warn you that now that may be delayed a little bit longer due to some staff changes. But work continues on that with the ever energetic Councillor Tully chairing that meeting with that committee with its usual aplomb. In December, now this work that you've been doing today around the JSNA leads obviously onto the support for that, the local JSNAs with Neighbourhood Health. So Zoe and her health partners will be bringing you an update on the work around the governance and the development of Neighbourhood Health to meet one of the fundamental objectives of the NHS 10-year plan as detailed in your reports today. So we propose to bring that on the 14th of December, and obviously as well Hilary will be bringing her usual budget outturn to both of those meetings.
Okay, any comments about the work programme? Councillor Thomas.
Well, I get more complaints about, I've got basically my ward, I've got two really GP practices, Kingston, which is right up there, very nearly the very best, was the very best. And I got Much Birch, which is way, way down there. And I get an enormous amount of complaints. And I think we need really to bring, we had a meeting here, a year ago with a lot of the GP practices, because some in Hereford are abysmal. And yeah, you know, and I think we need to sort of have another meeting with them and see if we can get some better outcomes.
Okay, so we can have a look at that to see which would be the best way to address your concerns, and whether it be an informal meeting with GPs or Taurus. We'll work that one through. Thank you. Well, we'll Taurus are the actual GP services, so they would be. It would be remiss of us to miss them out. Anyway, any other things to add on? Councillor Tully, you were frowning.
Well, yeah, I was. It is a surprise to me to hear that there may be a delay to the Adult Social Care Task and Finish group. So I'd like to understand a little bit more about the thinking behind that.
As stated, we'll be having staff changes, and that may impact our ability to support you in writing that up. So the word operation there is may. So I'm just sort of saying that there is a risk there due to staff changes. So we may have to delay the work involved in that. So there's only at the moment, as of next week, there'll only be 2 of us rather than 3 of us supporting Scrutiny.
I would like to just record that we'll have a conversation about this. I don't know how this works in this way, but currently I'm expecting that there will be from the group a draft in September for us to talk about, and I don't see a problem with us creating that draft as a group. And I know that Hilary, when we spoke about the timings of things, I know that it felt important to some of the people that would be in, would have quite a heavy role in taking some of these recommendations forward, that if those recommendations weren't shared in a timely manner, that they would not be able to be included within budget decisions of the following year. So for that reason, that's why I'm thinking it would be better to have something that was not out of date. And as the chair of that task and finish, I'm obviously happy to try and work towards that happening.
Yeah, I think we can talk about this in private afterwards. Okay. That's fine. You've noted it, and we also know that we're going to be one officer down from next week, and at that point I will actually thank you, Henry, for supporting us on this committee for so long. We will miss you, and good luck in your new venture. Okay, so we've got our work programme there. Are you happy to agree this work programme? All those in favour? Yep. Yep. Okay, unanimous, thank you. Okay, so that ends the meeting for today. The next meeting is scheduled for Monday the 14th of September at 2 o'clock. Thank you very much.